Andrea joined the Ohio Department of Mental Health and Addictive Services, OMAS, in the summer of 2014. Fortunately, you bring a wealth of experience as you have been actively involved in Franklin County. You were the administrator of the Municipal Court's Special Docket Programs. She was a Franklin County Alcohol, Drug Addiction, Mental Health Services Board Mental Health Coordinator. She has a master's degree in counseling. I've watched her in action with G-Code. You know how to keep people. G-Code is the governor's cabinet opioid action team. And there are a lot of strong-willed people on that, as I've witnessed once or twice.
I like how you say that.
And Andrea knows how to keep people focused. So this show is yours, and then we'll have question and answers. And please start thinking about that now. This is something that is a dialogue. It's meant to be a dialogue. And we want it to be enjoyable and fun and interactive. And I don't think with tonight we have to worry about civility, but civil discourse is essential to a dialogue. So that's part of this as well. So Andrea, it's all yours.
Thank you. So I was really nervous for the last couple of days, and I emailed Jose and Dr. Martin and said, what is this going to look like? Can anybody send me a video? Because of my style of presentation. My style is I typically stand up. It's very hard for me to stand still, but today I'm going to really put forth that effort because of this camera. But also the reason is because I'm really passionate about what I talk about, and sometimes the truth hurts, and I am often unapologetic for telling the truth. But I do it in a way that I think makes sense and that takes you on this journey. And it's a journey that you've kind of outlined, Dr. Martin, that has been incredibly frustrating. And not just for those of us in the state of Ohio, but throughout the entire nation. Because while we have this Midwest 5-state region, the reality is the difference between being number one in unintentional opioid overdose deaths compared to that which is number 10 is very slight. And so we're not the largest in landmass, we're not the largest in population, and yet receiving a phone call from a national news outlet to say, why is Ohio at the epicenter, is one of the greatest frustrations that I have. So I've had to do a lot of learning along the way. And I'd like to give a little kudos because I was a John Glenn 2000 fellow back in 2003 and 4 when I was at the Adam Board. And one of the things that I learned through the John Glenn Institute was you have to collaborate and you have to ask questions. And sometimes those questions can be uncomfortable. But you have to ask them and know the question that you're asking and what is the answer you're actually trying to get. So for me, prior to taking this job, I thought everything was pretty simple. I ran the mental health, the military and veteran services, the human trafficking, and the drug court for Franklin County. And in the process of doing that, I had to break down each issue. And at the root of each issue is, but for the mental illness, would the crime have been committed? But for the disease of addiction, would the crime have been committed? And that was pretty as complicated as it was because you deal with different human beings every day and it's the ebb and flow constantly. I knew my stuff. And so then when the prosecutor came forth and said, start a drug court, to be quite honest, I said no. I believe that the disease of addiction is one that, unlike most diseases, folk almost always have to go through a cathartic experience. And coercion, if you want to use coercion to put them in a drug court, well, we know coercion doesn't always work. That's the very basis of our criminal justice system. And it's not like we've decreased the number of jails and prisons we've built. So I didn't want to force it. And it was very funny because the judge I was working with at the time said, okay, well, you've got 2 weeks. So in other words, there was no choice. This has to happen for a lot of different reasons. And they dangled a carrot in front of me and I said, okay, we start the drug court and I looked at some data and one of the things that I found was the amount of time that people were spending in the jails related to their drug issue and what they ultimately pled to after often put them in a worse situation than when they entered the jail. So for example, the average charge for most folk was an F5, which is a felony, right? You're going to do 6 months. That's what they're telling you. and you sit in jail for 2 weeks, the first time you're arraigned, that first day, you're going to say not guilty. And they say, okay. And they put you in jail. And you sit for 2 weeks. And then they say, okay, we're going back. You're going to go before the judge. How are you going to plead? Can I plead guilty to a misdemeanor 1? Because if I can plead guilty to a misdemeanor 1, understand how felonies work. It doesn't endanger my job. If I'm receiving any entitlements, it's not going to endanger that. Maybe I haven't lost any of those entitlements. It's just a better situation all around. So the difference was 16 days or 3 days. And if you're going to get that person to plead, what is the option you're giving them in terms of understanding the impact of their drug use or their possession? So we did really well. And 6 months later, a different person from the prosecutor's office came forth and said, and I'll never forget this, they said, you gotta do something different for pills. And I was like, we treat the disease of addiction, we don't look at the specific drug, we da-da-da-da-da. And they said, that's fine, but you have to understand, their parents vote. And I heard it, right? And so began my history lesson, right? Because I thought I understood the issue. I thought I understood how folk would bang dope or go into a shooting gallery, and these are terms that are used for those who use. But when they said this to me, I said, okay, so now we're talking about re-election. Got it. Let me do my work. And as I started peeling away at this onion, what I found out is actually this drug is very different. I can talk about alcoholism, I can talk about crack addiction, I can even talk about gambling. And I know what happens to the brain. But the physical side of this drug, not just with the brain and the hijacking of the brain, but what it does to the body and the withdrawal, man, I had to learn a lesson. So we started this separate drug court, and there were things we learned all along the way. The profile of the patient. You know, when we first started the human trafficking court, it wasn't uncommon to have a woman who was charged, you know, maybe 18 misdemeanor charges, maybe 4 felony charges, typically to have a prison stint. And most of those charges obviously were prostitution. The typical diagnosis for that person was post-traumatic stress disorder, sometimes bipolar disorder, or major depressive recurrent. So it gives you a picture. Average age was 44. Within 5 years of starting that court to getting to start this now opioid-specific docket, the profile of that person changed. The average age was 26. The primary drug of abuse was not crack or alcohol, it was opioids and more specifically heroin. But different from the previous time that we've had this epidemic, previously, especially after the Vietnam War, primarily if you were just using dope, that's what you were using. You might use alcohol, you might smoke a little weed, but you really weren't messing with anything else. This client, if I can't get heroin, if I can't get pills, I'll use whatever I can get. So that kind of changes the idea of what kind of euphoria are you looking for, what kind of issue are you dealing with and exposing yourself to as a result. But we did good work. We got people into treatment. We expanded medication-assisted treatment. There was a cultural change that had to occur with the judges, and that was a tremendous challenge because, again, we have always criminalized the disease of addiction. It is rooted in the history of this epidemic. So today when I'm preparing for this, because I'm nervous and I got to get all my stuff together, I go back to my Chasing the Dragon book, which is a wonderful but very thick book. And when I speak, typically I talk about this isn't the first time we've experienced this. It's actually not even the second time that we've experienced it. The first time we experienced it was the early 1900s. Actually, the first time we experienced the use of morphine was during the Civil War, and we had tens of thousands of soldiers who were hurting from injuries from war. And then after that, in 1914, we had this change in the formulation. And so it was being prescribed primarily to white women who were seen as hysterical, depressed, or having mild mental health issues. Those that we would consider today certainly mild. And then compared to that, put the image of the Asian railway worker who's depicted as sitting in an opium den, dirty from the day of work, and compare those two images. And already you've set up a like and dislike scenario, or an acceptable and unacceptable scenario. One seems criminal or deplorable, and the other seems like, well, it's just a disease and an illness, and we just need to treat it a certain way. However, after that, you get what was called the Harrison Act. And when I talk about the Harrison Act, I talk about it in relations to prescribers and physicians. And a major change occurred as a result of that, which was, the federal government, the Department of Treasury say, we need to control how many of these drugs are actually getting out there. And the best way to go about that is taxing and registration. But we already had a large, large population of people who have the disease of addiction. So what do you do with them? And if you think about this, that's exactly what we're dealing with now. What do you do with this population that maybe came to this point not intentionally, not with malice, thinking this is where I end up, but as a result of a treatment that they were receiving? And so what happens? Doctors were told you're not allowed to prescribe that. And if you prescribe it against its medical description, which is only to use it as a cure, not as a maintenance dose, but as a cure. If you go against that, then we're going to have the feds come after you. And that's a major fear even today. What's another major fear of most physicians? Lawsuit. Malpractice. Getting someone worse off than when they came in. So I say all that to say, this isn't new. And actually, the current issue we're dealing with is rooted in that very history. Because another part of what I had to learn in dealing with people through these specialty dockets and the service that I do is an overwhelming majority of these individuals deal with trauma. And trauma's impact on the brain and how we treat it, and trauma's impact on pain and how we treat it with a painkiller is all tied together. And yet the brain isn't sitting there going, well, wait a minute, that's for your COPD, and that's because you hurt your knee, and this is because I had a horrible experience in childhood. You're not sitting there having that kind of dissection take place. So much of what I have to do is give people the history in a way that they understand it. Because when we talk about it in contemporary terms, in modern times, you need to understand where you've been, to understand where you're going, and so that we don't have the same mistakes that we've committed in the past. So I feel like I'm seeing some mistakes. And it's really hard, and you noted it. Sometimes when you're sitting around the governor's cabinet opiate action team and there's representatives from the Department of Health, the Department of Medicaid, Department of Veteran Services, you get it, Job and Family Services, and everyone pretty much, sometimes they sit quiet. And they just want you to do a presentation. And I got permission from Director Plauk and the governor's office to put forth a challenge. And my challenge was, so we've been having these meetings, tell me what you're doing. And what do you mean, what are we doing? I don't know how it works in academia, but what do you mean, what are we doing? Well, we've talked about the death rate, and we've talked about the expansion of naloxone to law enforcement. How are you getting that information out through your department? How are you showing? Do you have posters? Are you doing webinars? How are you training people on how to keep themselves safe when they respond to an overdose scene? When we know that 56% of the overdoses last year involved fentanyl. What are you doing? So now I feel like after that conversation, which was at the beginning of this year, we're really making progress. And a big part of the progress is understanding it's a disease and educating people on why it's a disease. And a lot of people genuinely don't know. So I talk a little bit about my personal life and what my own experience has been with using substances. And why is it that my body could respond one way, but my brother, who has the same blood, responds a different way? Well, we often have to compare the circumstances. My brother was very intelligent, graduated from Ohio State. I understand this is a goal now, but within 4 years. Really smart, really gifted. We call him Reverend Deacon Doctor because he's so amazing, right? On the AIDS Task Force Board, the Columbus Public Health Board, all of that. And then you had, like me, and I was like Winnie the Pooh, right? Like I'm short, fat, and proud of that. And I didn't think I was too bright, right? And I was good with jokes. And I was an athlete, right? But I had to wear Chuck Taylors because we were very poor. So when I say we slept in a 4-room apartment and I slept in the same bed as my mother till I was 15, do you start getting a different picture of my psyche? And the fact that in a lot of subsidized or low-income housing and apartments, here in the United States, we paint all the doors the same color. So that means everyone knows you live in poor housing. So where is my psyche? And then to have a mother who had 2 boys and her thing, and I love my mother, respect her tremendously, may she rest in peace. My mother said, mothers love their sons and they raise their daughters because this world is not built for you. So what does that do to my psyche the first time I go to smoke marijuana? It validates me. It makes me have purpose. It makes me finally feel connected when I didn't feel connected. My brother didn't need that. So how is it that 2 people with the same blood? Environmental, circumstance, genetics, socioeconomic. And I think that, again, when you look at the history, even with the Vietnam War, there was Operation Gold Rush, where they actually, 15% of those who were in Vietnam were heroin addicted, active soldiers. How do we bring them back? And in working with them, what they found was the biggest impact on the success of them not relapsing, only 12% relapsed within a 3-year period, change of environment. So if the environment is chaotic and stressful and traumatizing, and I remove you from that environment, what changes for you? I feel safe. And that's, again, an issue that we deal with trauma. So as we've challenged the states around the table, a lot of really cool things have come out. Now, yes, we have the 21st Century Cures Act, right? This is federal money coming down. We also have the Third Frontier from the governor's office, which has partnered with Ohio State University and said, we need to do some creative stuff. And I don't know of any other state that is doing that, nor do I know of any other state that has the comprehensive approach that we've had in the state of Ohio. I'm not trying to be that competitive Buckeye. I actually went to school in Maryland. But the reality is I sit and I look at what other states are doing. Here's where Ohio is really ahead of the game. Having a governor's cabinet opiate action team, that's number 1. Getting state agencies around the table and having a person say, what are you doing? What do you need help with? Do you have the right communications? Is huge. We now have videos that are being produced out of G-Code so that we can talk to first responders about vicarious trauma. One of the issues we're dealing with, right, is you hear in the news, EMTs are saying, no, I've saved that guy 3 times. I've saved that guy 4 times. There's no way I'm going to save him again. Well then, as a person who went to seminary, I say, wow, what a very powerful position to be in, to decide whether a person gets to live or die. And to, in essence, play God because you actually have the resource to respond. But I also understand where they're coming from, which is day in and day out. And here's what we're not responding to because we're responding to this. And this person chose it. And that's the lesson that we've had to change. No, they didn't choose it. They chose the first time. Absolutely. And then the drug chose them. And their brain was hijacked and the mu receptor, and this is all stuff I know if you're a physician or a prescriber in the room you get. But basically, this is science. This isn't some kind of alternative fact. This is science rooted in evidence and years of study. And so part of what I've had to do is translate that message, and I always get kickback, right? I go across communities all over the state, and I have to bond with them and let them tell me their story. And then say, okay, based upon what you've shared, let's work on a solution. One of the stories that I hear is, but wait a minute, you always say it's like any other chronic progressive disease that can ultimately lead to death, like cancer or diabetes, but a diabetes patient isn't robbing me. A cancer patient isn't robbing me. So what does that do? That forces me to go back and say, okay, how do I draw this metaphor? Well, here, I've got one for you. I work with a ton of people at the state who have insurance through the state, much of what taxpayers pay for, right? And I work with a lot of folk who have health conditions, high blood pressure and diabetes. Some of those with high blood pressure and diabetes are actually overweight. And they're prescribed medication from their insurance, which is paid for by the state, which comes out of your tax dollar. And they're told you need to lose weight, you need to follow an exercise regime, and you got to take this medication daily. And when they don't do that, and they end up having a heart attack, who responds to it? The same EMT that's responding to an overdose. And when people say, but he chose it, why didn't the heart attack patient choose it? They knew they had the disease. They knew what was recommended by the doctor. How does it make it any different? And I'll still have people come back and say choice. So my research, because my undergrad is in history and literature, says, oh, this is tied to morality and religiosity. This is tied to sin. This is tied to prohibition, right? Ooh. When we talk about trauma, I also have to deal with the trauma that's intergenerational amongst professions and cultures, such as the doctors who know of the Harrison Act, or maybe they don't know about it, but they've heard the lore, the stories. You don't want to work with an addict. Drug-seeking addicts are horrible to work with. This is what you want to practice. I also have to do the same when it comes to dealing with the religiosity. And so an example is last night I was talking, a wonderful place, if you've never heard of it. There is a retreat in Newark, St. Peter, St. Paul retreat. And they have an older population that they get together every month, and they want to talk about current issues so that they can talk to other people within the congregation. So I'm like, this is perfect, right? Like, this is like community organization at its best. And these are all folk, I think the average age, and please no disrespect to my elders with great wisdom in the room, the average age was 60, right? And they're saying, what do you mean? This is a disease. Why? What do you mean the pharmaceutical makeup, the molecular structure is like heroin? And then I feel like, okay, we gotta go back a little bit. So I take whatever I can and I said, just imagine this. This is heroin. This is the molecular structure of heroin. And I'm not a scientist at all. This is the molecular structure of heroin, and this is the molecular structure of Oxycontin. And yet, if a doctor said to you, I'd like to give you 10 balloons of heroin, and I want you to take one every 10 hours, you would be outraged. Yes, the medication is different. There may be an alkaloid that's added to it. The potency of it may be different, and it's monitored. It's watched. And what happened with this most recent round of the epidemic? We weren't watching. We weren't watching in the early 1900s. And we weren't watching this go around. And instead of sitting and placing blame, my job is to say, yep, you're right. Now what? How do we make sure this never happens again? So another community that I've had to go into is the urban community. And the response in the urban community, to be quite frank, is very different. When you are in an African-American community whose tradition is rooted in oral history, you don't have the same rate of the epidemic. Why? The previous time this epidemic was in the urban environment, in the streets, people talked about it. People said, you don't want to go down to 21st and Mount Vernon. You don't want to go to 154th and Kinsman up in Cleveland because, and they demonized it. And so growing up, that was the last thing you wanted to do, right? And we passed that down orally to our kids. Same thing with the crack epidemic. The only time we've ever named a child after an epidemic was a crack baby. What do we say now? We learned from that. So what are we saying now with women who are pregnant, who are taking opioids? Neonatal abstinence syndrome. We can learn lessons and change our words and change our culture, but we first have to acknowledge the issue and the differences, and then bring the experts to the table. And every community has their different set of experts. That's something I've learned a great deal of throughout the state. What you may do in Noble County is going to be very different than what they do in Warren County. What they do in Montgomery County will be very different than what they do in Fairfield County. And you have to respect where that community is coming from, acknowledge it, and start pulling on resources and coming up with a plan that isn't conducive to me or conducive to the state and the governor. It has to be conducive to the community so that we learn from it and history doesn't repeat itself again. Giving you a lot. And it's super hot up here, so I'm going to take some water. And if there's some questions, we can learn some more from each other.
So right off just maybe kick this off, I guess, except for a few people, I don't know the vast majority of you here, but I suspect one reason you might be here is that you also have a personal story. You have a perspective that you can relate to a friend or a family member. Because I think that's what's often missing, sort of as we get into these dialogues, is when you hear something, it becomes real. And instead of, I think this has come to the attention of the nation, in large part because it is all of our communities that are involved, although you might argue it's communities left behind, that where it really flourishes. And it doesn't make any difference if it's a rural community or an urban community. So do people have any stories they want to say or ask questions about relative to your own circumstance and some experience, friends? Because part of the discussion naturally comes from this. Because it's happening everywhere. There's hardly any one example.
Yeah, the book by J.D. Vance, Hillbilly Elegy, I think, I read the book, and for me, the book, there were more questions after I read the book than answers, and I think it was kind of frustrating reading that. Now I understand he's opening up a center down in the southern part of the city. Do you think that to some degree it's kind of sensationalized this whole epidemic and made it kind of a flashpoint right now?
Absolutely. It's being exploited in every possible way, not just from authors, from elected officials, from pharmaceutical companies. You know, I was shocked. I was thinking I knew as much as I could about the issue, and I was watching TV, and I saw anti-opioid constipation medication, right? And then I said to myself, I wonder who's producing that. Not in the conspiracy kind of way, but like, I want to start.
Movantic.
Thank you. Do they produce any opioids? Okay, just a thought. So it is being exploited, but not always is the outcome negative as a result of someone maybe bringing it to the head. So, for example, we've talked a lot about medication-assisted treatment and the need to allow the patient and the prescriber that leeway. Let the doctor be the doctor and the patient be the patient, whether it's methadone, Vivitrol, or Suboxone. And someone said, don't you feel like Suboxone can be diverted? Don't you think that methadone has such a bad rap? Vivitrol seems like the only way. And I had to really think on that for a moment because, one, I had to consider the person who was saying it and what they were ultimately trying to accomplish by having that conversation with me. I am a lot more suspect anymore about these conversations and trying to figure out what's their means to an end. But I do feel like once I've had that dialogue with that person, both of us have opened up our mind to, hey, maybe that's not a bad idea. Maybe we actually need to start doing, and this is what came from that conversation, I wanted to do mobile treatment in rural communities. I wanted to be able to provide mobile MAT, and this was right when I got to the state, and Ben left, but Ben used to be with the governor's office. And I remember, like, I go in and I'm like, well, this is what I'm thinking. We could do this, and then we could do that, and what do you think? And they were like, do you know the law? And I was like, oh, talk to me about this. Talk to me about this law thing. And they said, well, because methadone is a scheduled narcotic, it cannot be in a mobile unit. It is highly monitored by the feds, the DEA, what have you. I said, okay, well, can I put like Suboxone? Can I do Suboxone? Next thing, so this is, we're all learning together. Only a certain number of doctors have the DEA license to be able to prescribe it, and even if they have the license to prescribe it, some of them can only do 30 patients, 100 patients, and now 275. So who in Washington County meets that definition that's going to be willing to get on a mobile unit to go through the 32 Appalachian counties? So then I say, Vivitrol. You guys have not said that it's a narcotic. You don't have to have a special license, but you do have to be a doctor, right, or a prescribing nurse. How can we make it happen? And we had these conversations and we talked about it. My thought was like a mammogram bill, like we can do it. From that conversation with that person, I was at another time in Newark. She came up to me 3 years later. They're bringing a mobile unit program for Vivitrol to Ohio that they've piloted in Pennsylvania, again, dealing with the Appalachian regions. So it started off rocky, where I have an idea, I share that with her. Maybe it didn't happen in the timeline that I wanted, but it happened. And my hope is that no one got exploited or hurt along the way of this coming to fruition. But yes, I do believe there are those who are exploiting it.
Kind of just continue off that narrative and do my own personal statement instead. I currently intern with Jay Vance's new nonprofit here, ROI Renewal. So he's kind of taken that book and tried to look at some of the aspects of it. One being directly drug epidemic and kind of try to physically look at that philosophically. The cultural aspect of it, again, it's a culture in crisis. So how do we change the conversation around this and engage everybody in these communities, and then also economic development as looking at some of these things that precede the addiction and how to look at some of those. And I do think that people like Vance and others that do highlight this, or even part of pharmaceutical companies, do have the opportunity to exploit it, but I also think that they are the people that are in the best position to also help the epidemic and have the most ability to leverage that help. So I also have done a little bit of work here with Professor Douglas Berman, who looks a lot at marijuana specifically. And my question for you really is, what do you think about other non-traditional modalities for pain management, including marijuana, physically, like some yoga or meditation? There's been new studies about the psychological and physical aspects of pain management. So what do you kind of think that role plays in?
So I believe, so again, my background history, when I look at the civil rights movement, there was no one way, right? Like you had Dr. King, you had Malcolm X, you had the Southern Poverty Law. Like, I don't care what way we get there, I just want to get there. And I don't believe in prescribing for a person their route of recovery. I don't think I have that right or that power when you bring up alternative options. So one of the things we did with the G Code was we had to come up with the prescribing protocols. And this was like a real lesson for me. There were probably 75 different folk around the table, some physicians, some nurses, a lot of lobbyists, and a lot of attorneys. And I guess the hardest part was we want to come up with prescribing protocols, but we need to talk about what the options are. And so we came up with great options, chiropractor, physical therapy. And actually most of the physicians and nurses around the table said, in all honesty, and it came out of a Cochrane review, the most effective way to deal with pain on X, Y, and Z surgeries are acetaminophen and ibuprofen because it decreases swelling and increases blood flow. But most people don't know that. So it's getting that information out. But then we got ourselves into a little spot because we didn't have the managed care people at the table. So while we're sitting there talking about alternative ways to address it, well, okay, you can say I can do physical therapy or go to a chiropractor, but what if my insurance doesn't pay for it? So we round them all back up, and we have further conversations, and I'm happy to say, even acupuncture under some of those managed care plans, chiropractic, physical therapy, meditation, they're being covered. But under most, they're not. And as far as marijuana goes, I stay away from that discussion.
I should just representing the healthcare. I'm a primary care physician. My first 14 years of training and being on staff was at the Mayo Clinic. And the Mayo Clinic had a fabulous integrated pain management center. So even back in the 70s and the 80s. You would see people with chronic pain who were on a narcotic, and you could send them to this integrated pain management center where they would look at dependency and addiction issues. But they had all the alternative pain management strategies available. And that went away in the 80s in a lot of academic health centers because of reimbursement.
Right.
Because it was cheaper. Third-party payers recognized, well, writing a script that fast and easy. Pain management centers, sometimes there'd be a 1 or 2 week stay in a hospital. And then you'd be transitioned, you'd have follow-up care. And so much, we live in a capitalistic society and our healthcare system is capitalistic. And part of our challenges is it's like deep throat in the Watergate. You gotta follow the money. Because oftentimes that leads you to why policy changes were made. Just to that point. So in the corner?
I have a really good question. So I think this was true about 4 years ago. I'm not sure if this is still true. I'm wondering if you don't have insurance in Ohio and if you are told by the board or you decide to put yourself into rehab, and so you're going to like a state-funded rehab and you're basically not paying because you don't have insurance, so the state has told you need to, or you're gonna. I don't know if you can even put yourself in without paying, but all of those ones that are state-funded, is it mandated that they are a 12-step program? That used to be true.
No.
It's no longer true.
It was never true. It is preferred to also use in conjunction with MAT and counseling, but it's ultimately up to each institution. Many state institutions always offer it because
people funded by the state. You don't need to have a component of 12-step program.
No,
okay.
That would be really dangerous, and because it's not treatment. 12-step is fellowship, and you can't mandate fellowship. And you said something else about the insurance, which I think is really important to mention in terms of our current state and what we're dealing with nationally. We had over 500,000 people who receive services either for mental health or for substance abuse as a result of Medicaid expansion. That's 500,000 individual touches. If that goes away, what is the impact for our community? And we kind of know, because we know, even when you talk about being at the Mayo Clinic, when you have a lack of insurance, first of all those issues that led to this point of the disease are exacerbated, but also who becomes the primary health care provider? The emergency department and the jail. We're really trying to prevent that from happening, but having these conversations in silos with people who we know the issue, but the issue has to go out into the community because they really do need to talk to their elected officials and say, and I've heard this, I've literally seen this happen. I've known you since you were a little boy. I can't believe you would vote against that. Sometimes it's educating the community so that they can call their elected officials to the carpet and also talk about the real impact. Yes, the economic, which is huge, but the real impact, and make sure that that person feels that connection to community and the human condition.
And we have,
Sure. Thank you, Dr. My name is Jose and I work in public health. So a couple of years ago, we ventured to change the law in the state of Ohio so that we could actually have legal access or legal exchanges without a Board of Health issuing a public health emergency. So now we're able to do that throughout the state thanks to great leadership at the state government. That being said, I happen to volunteer on Saturdays at a legal access project in which we provide on a Saturday, how many run? Maybe 70, 80 people with clean needles. Of course, we have an outbreak or an epidemic of hepatitis C, which is the reason why we provide clean needles to people that are addicted. Could you talk a little bit, because we're really under quite a bit of fire for, as critics will call it, enabling people to use by providing the clean needles. So actually, either from a medical standpoint or from a treatment standpoint, can either one of you address that?
I hope we both can. From a treatment standpoint, first of all, I commend you for what you do because it is very difficult. And we do have, it's the same conversation when we talk about saving a life with naloxone or Narcan. Well, aren't you just encouraging them to do it over and over again? The disease of addiction is not that simple. It really isn't. I have, and when you said the needle exchange, what's really funny is I remember when we were working on that legislation and that law, and I think you and I were in the same room, one of the things we were told is you can't say needle. Like, this is how when you talk about the policy, you can't say needle, and you have to say bloodborne pathogen. Don't cite the actual, so again, I'm learning all along, and I realize, but sometimes you have to say what it is. And when we're talking about the disease of addiction, here's the option. If we don't provide the clean syringes and the clean equipment, and typically for a one-to-one exchange or bring in whatever you can, what happens as a result? What is left within the community? What happens with regard to relationships that that person may have, or the sharing of those needles and the expansion, as you say, of HIV, MRSA, and hepatitis C, which the Department of Health is able to track? I've gotten really kind of angered, and my statement is usually, okay, well, here's your other option. We talk about it with harm reduction. So this is really about harm reduction and reducing the likelihood. If I have a person who tells me I can't stop using, but they still have custody of their child, I know what the data tells us of the number of children who've had accidental, unintentional overdoses from opioids in the state. So when I say to that parent, here's a lockbox, am I really telling that parent to use? Or am I saying that I want to keep that child safe? I can't stop you from using, and I also can't make you use. These are decisions that are tied up in your disease. I can't progress your cancer. I can't do that. That's all within you. But what I can do is to give you safe options to reduce the likelihood that a child gets hurt, that a disease gets transmitted, and possibly that you become infected with another disease that will cause your death. But medically,
Well, you know, I understand. First of all, we start with a disease like addiction and frame it as a brain disease. And it's not like alcoholism, which occurs over decades typically. This is something that can be a month, 6 weeks. You are a different person. It's hard to believe if you see it in a loved one. You can't believe it. That person who had ambition, who was going down this path, and for whatever reason is down an entirely different path. And when it's your child, you don't look at that and say, you know, this is a moral failing. You say, how did this ever happen? So we have to destigmatize this. We have to remove that as best we can. And a harm reduction clinic where you're trying to prevent Hep C, HIV infection is right at that interface where the discussion happens with law enforcement, for example. But even law enforcement, as they look at this, and you talk to policymakers, let me tell you about the state of Louisiana. So Rebecca Gee is the HHS director of the state of Louisiana. The name Gee is perhaps familiar. She's the daughter of Gordon Gee. She's an OB/GYN surgeon who, like myself, later in life found public health. But her quandary is she has 35,000 people in the state of Louisiana who are Hep C positive and eligible for treatment. In the state budget for Louisiana, they have enough money for 300. Now, think about that. What does Hep C treatment cost? Probably can be as cheap, maybe as $30,000. Could be as high as $60,000. Multiply that times 35,000. A liver transplant, which occurs if somebody gets Hep C, they fibrose their liver, they get cirrhosis, $500,000, $600,000. What does that do? So even if you say this is a moral failing, even if you say this doesn't happen to people like us, this is them. And I must admit, you didn't say it, Andrea, but in the 90s with crack and meth and everything else, and it was in the African American community and urban centers, it's them. Well, this is us. It's everybody. And this awakening, in some ways, I think is a good thing. Because our beliefs are often built on these biases in the case of racism, and you just got to call it out once in a while. But in this case, you cannot look at this from an economic standpoint without saying it's mind-boggling. So if you want a positive note, Rebecca Gede was one tough lady, has gathered a group of experts from around the country, and there's a 1910 patent law that was created because up until 1910, the U.S. government just took things they wanted. If you invented a really cool thing and we could make a better cannonball out of it, we just took it. And what happened was in 1910, they said you can't just take an invention from somebody. You have to pay for it. You have to pay a reasonable cost. And this patent law has been invoked in the 20s, the 30s, the 40s, kind of disappeared in the 60s. It came up again in the 70s and 80s, in part because of HIV. Wasn't invoked. She'd like to invoke it because all of a sudden if you were talking with pharmaceutical companies and say, by the way, we don't have to spend $50,000 a year for Hep C treatment. We will tell you what we're going to give you, and that's going to be the price. It's really a leveraging tool to get pharma to the table. And we need discussions like this. You know, we all, if you've read Dreamland or Hillbilly Elegy, you know the story. I mean, pharma, particular big pharma companies, were causative. I was going to say complicit. They were causative in this process. Pharma's a way out. Pharma can help. They need to be at the table. So I think harm reduction is a smart thing to do. We should be doing it everywhere. Fortunately, in public health, we have one of our faculty who just got a grant from NIH to begin the process of bringing the community of Scioto County, Pike County together to do their first harm reduction clinic. It's slow, it's hard work, you gather, it's community engagement. But I would argue everything that's important to do in this business is engaging communities, bringing people, again, back to the table.
I have to say, one of the things you noted that's interesting is when we started looking at naloxone and trying to first, because before House Bill 4, you could only get it if you were prescribed, right? And we're at an epidemic. So no, we need to have easy access, over the counter. We found our way through it and have a standing order. So now you can get it at any pharmacy. But one of the things we did is we worked with Dr. Aaron Winstanley and Dr. Feinstein down. They were both at University of Cincinnati, and I think they're at West Virginia now. And they did a cost analysis of an overdose. What does an overdose cost to the emergency room? What does it cost if the person, which many of them actually it happens, have to be put into a coma? And how long, if the average length of stay is 7 days, what is the cost? Then I found out that there is a IRS clause that requires nonprofit hospitals to make investments in the community if they want to keep a certain status. And so I thought, okay, so this is great. Like you can say, if the average 7-day stay cost $125,000, right, for one person, and you're trying to get the hospital to make a contribution of just $50,000, which could have a tremendous impact on the prevention of death, the keeping open of that bed. So people went to the hospitals, and the hospitals were like, yeah, that's not going to motivate us. But then when I pulled up the IRS clause and said, you want to do diabetic screenings, you want to do obesity screenings, this is just one more tool that you can meet this need, and the impact is going to be tremendous. But it's another example of sometimes, unfortunately, you have to show the cost. And that's when it gets really, I learned that in working with the judge. Yeah, it's about community safety. It's about cost. And if you can show cost savings or at least cost shift that has a long-term impact that's better, you have to show it. Thank you for that question.
Would you sort through the reasons for the dramatic increase? Addiction has been there forever, drugs have been there forever, depression has been there forever. So the issue is why this astounding increase. So we're using the word epidemic.
Right.
That's new.
So one of the things that again, just my interest in history was trying to figure this out and remembering that this wasn't new. So what I had to do was when we started looking at the data, and Norman Hall, who was the former director of the cabinet, he loves data. He loves it. But I couldn't read it, right? I couldn't understand what he was saying. So I said, please dumb it down a little bit for me. And he said, whenever you have almost a 1-to-1 ratio, that is statistically significant. And what we've tracked is for every increase in prescribing, there is an increase in death that goes with it. So when we first got the data from 2012, someone said, oh, this is the cartels, this is heroin. This is heroin. And then I looked at the data and I was like, no, it says only 39% are from heroin. So if it's not from heroin, what's it from? Pharmaceutical companies, right? It's from pills. Because only until recently, it's only recent that you now have some of the cartels and mafia, and I always make sure to add the mafia because all your ports are controlled by some. Anyway, only recently have they started making what are called caps, fake pills. But prior to that, you couldn't get a pill unless it had been prescribed. Now, I could do what was called pinching the bottle. So I could come to your house and take 2, and your house and take 2 in your house, and you're never going to miss it. But it pretty much was because most people keep their extra medicine in their cabinet. So it was an over-prescribing and the availability to people to take it. Some who maybe had received, in fact, I think what our data showed us from the Department of Health was 75% of those who had died, the decedents, had received a prescription within 10 years prior to their death. Now, that kind of leads to the chronic progressive disease nature, but it wasn't enough. And so I was like, okay, well, obviously this is coming from the pills, and those are prescribed, and we have to come up with prescribing protocols, but can you really say it was the intent of the pharmaceutical industry? Well, I found out that it wasn't until 2001 when we actually start to see the uptick in these pills and the deaths that the FDA allowed for pharmaceutical industries to start advertising on television. That had a huge impact on anyone's ability to go in and do a self-diagnosis. And then culturally, what do we always hear about physicians? They don't have time. You need to hurry up. So I've got my signs, my symptoms, what I need to do, and I think I know what I need, and it's going to make the doctor really happy when I go in and say, I have a really dull, sharp pain, never had it before, I fell off the ladder, if you could just give me something. And even the patient is genuinely just wanting to address that pain. But then after 3 months, the doctor goes, you've had physical therapy? You've got range of motion back? This isn't adding up. We're going to have to stop prescribing. But remember what I said about trauma? Maybe my issue opened up because of this, but then you opened up Pandora's box. And now what trauma, what pain am I actually treating? Am I treating this or am I treating this? And it's not as though our medical profession has allowed for those conversations and dialogues to occur and screening tools to take place because it's this rush. He said it's billing. So now what are we doing? Hindsight 2020. We've instituted SBIRT, the Screening Brief Intervention Referral Tool, to open up the dialogue and the conversation. We just finished our social marketing campaign that was covered by the CDC and the state that is an open website for professionals, so prescribers, patient, and then layperson who just wants general information. And it's real simple. It's not all those bells and whistles. It's what kind of questions should I be asking my doctor? What are my alternative treatments? My only concern in all of this is as we go to address the issue, part of what I, Andrea, personally believe that got us here is being disconnected. Being disconnected from community, disconnected from family, and disconnected from institutions. And often it's all of our electronic media that allows that to occur. And unfortunately, in treating this issue, some people just want to go to the media and get their answer. It's more than just one answer. But I tend to think that our culture is one and done. Give me one pill so I can be done with this. Can you give me one answer so I can be done with this? It's not that simple. But I know that what's led up to this is our history of dealing with the disease of addiction, our inability to appropriately monitor pain medication, whether that was intentional or not, and our desire to treat the disease of addiction as though it's a moral failing. And we continue, despite the evidence, to challenge that. So it's a cultural change and a cultural conversation that needs to shift.
We have a Facebook audience question. Justin would like to know what is the best way to tackle the access problem in Ohio, particularly in rural areas where treatment may be over an hour away from people who can't get there.
Right. So we've had some unique responses across the state. Wood County, for example, is a community that recognized it could be 30, 40 minutes before you could find a treatment provider, and many people didn't have transportation. So they did a community collaborative, the Job and Family Services, and more specifically across the state, we have alcohol, drug, and mental health boards that can help you in gaining access. If you're a female, a woman, which is considered a priority population if they're pregnant or with children, we have what's called the Women's Network, which means the treatment may not necessarily occur within your community, but we're going to find you the first available spot for you to go. If you can't do those things, unique programs like Wood County is, we're going to get a van from a local vendor, get them a tax write-off, get them something else. We're going to get Job and Family Services to provide the driver because they frequently have them through Children's Services that are already liability waived, and provide transportation for those who are 200% below poverty. But all that I just said to you, if I'm a person who's in the throes of it, am I going to know that? No. So we have a crisis text line that you can call, and I'm going to ask my friend Nicole to yell out the number because I think it's very important because most people are using technology. So what's the crisis text line? 741. Yeah.
741-741.
Got it. 741-741. Text it any time of day. It is a 24-hour line that will help you get connected to treatment.
One of the challenges with this topic is everybody's going to need some antidepressant as you leave. Sarah, do you want to stand up for a second? So this is Sarah Nerat. She was the creator of the Collegiate Recovery Center at Ohio State University. It is a national model. And can you just tell a little bit about, no, I know, but just tell a little bit about how that works, and for students who have had addiction problems, how they come back to a place like Ohio State University and succeed.
Speak loud, too.
Yes.
Yeah.
Yeah, come on up here. Here.
And I will say this as she gets mic'd. There is so much hope.
You're fine.
There's so much hope in recovery, and the reality is we had our recovery day at the State House, and when you see over 1,000 people who come together and say, I've had this journey, and thank you for your support, thank you for not judging me, and thank you for giving me the opportunity, that's a tremendous incentive for others who are going through it to reach out, and it also gives people hope. And a lot of times with the disease of addiction, rooted is a lack of hope that things can get better. So we like instilling it, and this program has done phenomenal in instilling hope.
So I'm Sarah Nerat. I'm a person in long-term recovery, which for me means I haven't used drugs or alcohol since August 16th, 2007. And back when I was at Ohio State, I got to come here as a grad student and build our collegiate recovery community. So it's about 5 years old now, and it's this whole support program right here on campus. It's free for students, where they can connect with their peers that are in recovery, because a lot of times they're a little bit older. They feel different. They're looking for that positive, sober peer community on campus, and this is just your go-to for instant connection, instant community, instant fellowship. It has staff that are dedicated to the program, so you need help, with your financially got screwed up because you have a criminal record, or you're having issues navigating resources that you need, whatever it might be, our staff help you to do that. We offer recovery scholarships. There's a 28-bed residence hall. They have a drop-in center in Lincoln Tower. If you're over there on the 12th floor, there's meetings. So I know people wanted to come to this, but their weekly meeting was same time. So yeah, there's about 200 of these across the country, and I'm that annoying former staff member that doesn't seem to go away. I put myself on their board, and I'm still helping them. So this is a huge resource that you have here at Ohio State, and really that we have here in Central Ohio, because high school students that are looking to find people somewhat close in their age I look like I'm in high school, but I'm not. I'm like not quite cool enough for them. This is the best they've got a lot of times. You know, is college students doing the deal, right? Like everyone wants to be a Buckeye. As well as Columbus State students, we've had folks from some of the surrounding colleges that are smaller, and these students are just like, I feel alone. And this isolation is one of the worst things for a person that's in recovery. And so this is a great resource. So support it, they accept donations, they do sober tailgates, all that. So thanks for letting me talk about that.
No, thank you. So we have I was told, hard stop at 6:55. So we've got 6 minutes. Have at it. More questions?
Pardon me.
What is the biggest myth that you would like to take the chance to debunk?
Oh man, there's so many.
It's a tough one.
There's so many. My biggest myth that I will say, I have never in 20, I'm doing my math, okay, because I told you, 26 years, I have never had someone say, I only used heroin once. Never. I think that's an unhealthy myth to keep telling people, or that you can use it once and not get turned out. You said it, the progression of this. Here's just a small example. When we would see the criminal records when we started the opiate court, I was always ready, because I don't know, I thought, I watch a lot of Law and Order, so I was always ready to go through their records and see what they were charged with and how they got to this point. I would have a 23-year-old male who maybe had one driving charge, like a accident or without a seatbelt, and then all of a sudden, 2 years later, they're charged with 3 felonies. That's how quick you go from 0 to 200. And you have people saying, this was the other thing that fascinated me. Everyone says, well, you always start with marijuana, you always start with alcohol. No, I had a lot of clients who were opiate naive. And opiate naive is those who maybe have never taken it or didn't start it until later in life, like they had an injury or a surgery. And like I said, it just opened up. So we really have to debunk all the myths about use, which also include you can use it once and you'll be fine. And also that people start off by injecting. I had a student who was here at Ohio State who was in a fraternity. He said his boys and him were getting high, and they sprinkled it on the joint at Ohio State. And I'm not saying that to say, it's everywhere. And now the one issue that we're dealing with is the cartels, much like any other business that likes to diversify their product and bring on new customers, is sprinkling it in marijuana and cocaine. Why? Because I can expand my customer base. So, and sometimes it's fentanyl, and you think, I'm just smoking marijuana, and that person doesn't come back. I think you all know the severity of opiates, morphine, fentanyl, carfentanil. And fentanyl and carfentanil, you literally can be absorbed into the skin. And we've had, like I said, 8 children and a couple of officers who started that overdose process that have been rushed to the hospital. So hopefully that tells you, do away with that.
Questions?
Is there anything that we can learn from opioid epidemics in other countries that were either resolved, like China under the Cultural Revolution, or India, places like that?
This is a really controversial topic because of what Portugal did, in that they decriminalized, but everybody goes to treatment, and it's not an option. You're going to treatment, and there was actually a period in the United States when we did that in the early 1900s, and it wasn't proven effective. But I think we can still learn something from that model, but it also means that it's institutionalized. So if you look at like when we had TB hospitals and TB clinics, we may have to look at that model again of the state being the one to provide the treatment. Certainly during a previous period of the epidemic, we had state psychiatric hospitals that were being treatment providers for heroin addiction. The thing was, most of them weren't equipped, nor did they have the skill set and knowledge of how to deal with the disease, But I think if we could have a marriage between looking at the TB clinic, looking at what they're doing in Portugal, and then looking at the current knowledge and skill set and resource we have now, that might be a really effective way to approach it. Just a suggestion.
It's interesting that you say that. I'm a pulmonary doc, and so tuberculosis fits
That's
within
your
my
area.
specialty. And for probably starting in the mid-'80s, but really picked up steam in the '90s, inadequate treatment of tuberculosis was everywhere on the planet. And so the problem was somebody took back then, most protocols were 6 to 12 months. But if you stopped at 2 weeks or 2 months, it would come back. And when it came back, unfortunately, the tuberculous bacilli adapted and became resistant. And so resistant TB started. They reversed that trend by something that I've often thought could be applicable to medication-assisted treatment, and that was directly observed therapy. So when you came in, you took your TB drugs. Somebody watched you swallow it, you went home. And it's inconvenient, but it worked. Now, how that can work with MAT, I don't know, but you didn't have a problem with diversion of drugs with TB. You do have a problem with Suboxone and methadone being diverted. And so if you receive it and you swallow it and it's gone, that might be one option to think about.
Guess what? Johns Hopkins has developed it. And it's actually an app on the phone, linked to the computer, and the direct observe, like you said, because the sublingual, you have to. But not everyone is on board with it because it's new, it's different, and it involves something that's, modern technology driven. But it's there. It's there. There's that.
Yes, Facebook question?
Yes.
And then you.
Sorry.
I'm sorry. Kim wants to know, what have you seen in terms of success with the holistic approach?
Is that person asking? I mean, without medication-assisted treatment, we would just call that old-fashioned recovery work. And so there has been a history of recovery that did not involve medication-assisted treatment. In fact, we have to be honest, there are still certain places that would argue it's not appropriate because you're substituting a drug for a drug. I typically go a little bit further with that, and I have to because he asked the question. I take Januvia for my diabetes. I would dare someone say I have to take metformin or insulin, or that I can only take it for 2 years and I should be cured. No, it's a chronic disease. The same with methadone. People don't like methadone because it's so da-da-da-da-da. That's all rooted in history and culture, bottom line. People don't like Vivitrol because you don't deal with what's at the crux. Actually, if it's properly prescribed, you're going to have individual and family counseling. But let's say none of those is being applied. I have seen people recover who do, and I don't like this term, but they do the cold turkey or white knuckle it. But it has to be a really conscious decision where you're surrounded with healthy, supportive environment, and that maybe if you're using holistic, that you're using healthy, holistic alternatives. I've seen it. I have seen it, I'll be honest. But this time around, not nearly to the degree that I've seen the success with MAT.
So we have one last question, please.
All right. So you mentioned a couple of interesting things, like the Vietnam study is really interesting, things like that. And you also talked about getting to the root of the problem. And so kind of going beyond just treating the addiction, how do you change the environment that the people are in? And how do you work to, is there a way to do that? Or because ultimately, I don't know, ultimately that seems to be one of the bigger roots of it. It's not just the addiction, it's and even if they get assistance going back.
How do I stop being poor?
Yeah.
How do I stop being treated with institutional racism thrown at me every day? How do I deal with sexism? How do I deal? It's possible. I mean, that's the bottom line. We have women who are in the institution, women who are in the pulpit, so we know it's possible. But there has to be, again, a conscious decision to want to make that change. And if I'm so invested in my own success, how much am I going to push your agenda? And I'm not just saying that if I'm a pharmaceutical company. I would say it if I'm an elected official. If I make that kind of change, what's the impact going to be on my quality of life? We still very much have this idea of it's all about me. You know why I love global thought? Because I know if everyone else is doing well, I'm going to do well. If my brother is hurting, then I'm hurting. I'm not just my brother's keeper, I'm my brother. And yet our mentality has steered far, far, far away from that. And I'm not saying that's rooted in religion. That is just how our culture actually sustained and evolved over the years. We took care of each other. We are far removed from that, but my hope is, I know we can do it. It has to be a desire to do it and not hide in stigma and in shame, blame, and guilt. And that's the biggest agenda for us. Over the next year, we're going to keep expanding MAT, expanding the workforce development, making sure we can get people in the right areas, but we also have to address the stigma and stop shaming people.
Thank you. And I would like to thank the John Glenn College of Public Affairs for this dialogue. I want to thank each of you. Dialogue only occurs because you ask the great questions. And Andrea, most of all, I want to thank you for your wonderful presentation.
Thank you.